So this is TTP then and now. And I would like to reinforce that I'm going to be talking about TTP acute episodes, not in a great, depth, but do sort of take care of yourself, listen to how you're feeling. It's okay to log off. This is being recorded, so, you can always come back at a different time. But do just, make sure that you look after yourself. And, if you are having a bit of a reaction to it, that's absolutely fine. So here's a bit about me. I've been a haematology nurse in London for 10 years. I started in haematology at the Royal Free, where I was working as an inpatient and never heard of TTP. And then I moved to UCLH in 2015, and that's the centre, now it's the Centre for the Southeast, but that was sort of the lead centre in London. And I heard about TTP very quickly when we got our first, to me, TTP patient on the ward. And it was, frightening. It's acute. I'd never heard of it. And it was just very interesting. In 2017, I left the wards to work in the Macmillan Cancer Centre, which is the outpatient setting. And again, I met everyone having their elective rituximabs, and it just seemed it's such a diverse patient group that when the opportunity became available to apply for a TTP CNS job, I went for it and got it. And then in 2022, when the commissioning came in, I became the lead CNS at UCLH. The reason why I'm giving that history is because I'm going to talk about TTP then and now, but very much from a nursing perspective. That I will talk a little bit about the treatments because it's relevant, because it affects you, the patients, and that affects the nurses, how we need to respond and care and treat you. So so this is going to be really from a nursing perspective and how that's changed and what's required of us now, especially with the TTP commissioning. So as Joe mentioned, 1924 TTP was first described in New York, and I think that was a 16-year-old girl. And this is a very quick rush through decades. In 1947, it was named thrombotic thrombocytopenic purpura. I forgot to put that bit on. And then in 1966, it was classified a bit more. It was given the sort of 5 main symptoms that people can present with. In the 70s, it was shown that plasma infusions were shown to be effective to be treated. But really during this time, the outcomes for patients were not good. It wasn't sure what was happening. It was acute, it was sudden, and there was no real understanding of why, although research was clearly being done. In the 90s, plasma exchanges replaced infusions. And the 90s just doesn't seem that long ago, when I was sort of capping the history. So then it still would have been unsure of why relapses were happening. So for the medical team and the nurses looking after the patients, it was very much dealing with the acute situation and not knowing when it was going to happen again or why, or, how to prevent it or how to see it coming. And then we're in sort of more of a current era. And there's some really important milestones here. In 1998, the TTP network was founded. I hope that's the correct date. And that really shows that at that point, it was identified that this is a rare disease. And they had more understanding then, although ADAMTS wasn't identified till a little bit later. They did know what was happening in the bloodstream with the VWF, and to some extent. But I think that date, if you look back to the timeline where we'd only just started using plasma infusions, there was probably some immunosuppression. The fact that, people were going through this and there was no support, there was no, information out there. There was barely the internet. So I think that just shows how important the TTP network being founded was, to be honest. Then in 2001, ADAMTS 13 was identified, and from then, the care that we were able to provide, it was a marker that we could monitor. So it was nothing random happening. In most cases, it is that it can, we monitor it, it tends to slowly go down, and the treatment then can be moved from an acute setting to elective planned treatments, where we can work with you around, if you're going away, we can test. So that's a huge thing for nurses to be able to support you through. And then there can be a bit of back and forth about when you come in, but then that also sort of indicates that there needs to be regular coming in. We can see that it's a marker that goes down. So that's why these, 3-monthly, 6-monthly appointments are so important. And lifelong follow-up is important, although we're not there yet in 2001. In 2005, rituximab became standard of care. And that's important because that means most people should have been getting it. And then, 50% of those people achieving a lifelong remission, even though we do have people who relapse sort of, 10 years, however many years later. And that's an ADAMTS relapse of the ADAMTS going down. So even if you had your episode a long time in the past and haven't needed any elective treatment, it's still so important to attend your ADAMTS 13 testing. In 2009, the TTP registry has started. This is another important date because this is, the start of a real collection of data in a really rare disease. And so it is not easy to get, a cohort of people where you can make meaningful conclusions about how to treat them, what symptoms they have. And so I don't know if you've signed up to the registry but it's still going, and and now it's a huge database that has really allowed for TTP treatment and care to progress and move on. And it was part of what got us to this stage of being commissioned by NHS England, which I'll get to later. In 2016, so just a brief recap, rituximab is an immunosuppression. It's an anti-CD20. So that is what is switching off the TTP, an immune TTP. In 2016, caplacizumab trials completed, and that became standard of care. So by then, we now have the standard of care that we have now. So rituximab, steroids, caplacizumab, plasma exchange. There are variations on this, but this is sort of where we stand now, outside of trials. You might hear a bit of noise. It is bedtime in my house. I normally do it, so my husband is, but if you can hear wailing in the background, that is because, it's bedtime. And then in 2022, I've got a 2-year-old and a 3.5-year-old, just for a bit of context there. So in 2022, it's the NHS commissioning NHS England for 9 national TTP centres. And again, that is such an important date because it allows us, it recognises that TTP patients need to be treated in a specialist centre, and that affects outcomes, that affects quality of life, and it validates what every TTP patient with TTP goes through, and the fact that they need nursing care, they need CNS, they need 24-hour access to their team. They might need psychologists at some point, and it might be at the point of diagnosis, or it might be 20 years down the line. But the care needs to be standardized across England, because if you have such a rare disease and you have someone being looked after and they're the only patient in that hospital in that area, it's through no fault of the medical team in that hospital that they don't know, the ins and outs. And, because how can every hospital be an expert in every, rare disease? It's just not, feasible. So I think what we'd say is that throughout all of this time, patients with TTP have needed and, you know, deserved support, individualized care, but it's taken a little, you know, it's taken this time to get there. But we are at the point now where it's something that we can offer in England because of the specializations of the centres. And that is because the work put in through the registry, through the consultants, through the team, and the network as well, the TTP network. So TTP then, well, it was plasma exchange, monitor the platelet count and hemolysis markers. People would have multiple clinical relapses, you know, sustained remission would be luck rather than planning. No regular monitoring, you'd have your episode and then off you go, and then, you know, all the best to you. And that meant poorer outcomes for people who are diagnosed with TTP. I think something I haven't put here as well is all the work that's gone in to get people to diagnosis, to get TTP in clinicians' minds when the picture presents. So there's, you know, that whole side of things of this is if you get to diagnosis. And, you know, it's not easy to diagnose, and people do incredibly well to do it now. But that's taken a lot of work with education. And no dedicated team, limited nursing support. So, you know, there wouldn't be TTP CNSs. So, you know, if you're looked after by nurses, for example, when I was on a haematology ward at the Royal Free, I'd never heard of TTP. If a TTP patient had turned up, which they didn't because they were filtered to an appropriate place, we wouldn't have known what to look out for, what they had gone through, and that would make it very hard for the, you know, the patient to trust us to look after them, and it would be hard for us to look after them. So TTP now is a much better place. We have ADAMS 13 testing and we can monitor it. I think it's so, sometimes on diagnosis, it's, you know, devastating to hear, but a positive is there is, you know, there is a diagnosis, there is something we found, it is very treatable. It's very dangerous, but it is very treatable. And we've got a marker for it. There's a lot of things that there aren't a marker for that you can watch and you can know how you are from it. People's as it gets lower, you know, that's when how you are feeling comes into it. And some people never notice. Some people get very symptomatic with an ADAMS 13 of a higher level, where someone else would never know. And that's when getting to know your patients is really important. Plasma exchange until the platelets normalize, and use the caplisuzumab as well. Steroids used in the short term. This is an important one for nurses to remember, your CNSs and you, because steroids affect your sleep, affect your mood. So while our patients are going through a very difficult time, we also have to bear in mind the medications that we're giving them will make their moods fluctuate or can make their moods fluctuate more. So we need to remember that when, you know, perhaps people's behaviors are a bit erratic or not what, you know, so we need to remember a lot of kindness, and that, you know, it's stressful in of itself. Plus there's going to be a million other factors because no one comes in with, you know, no history, no family, no, you know, like there's always some background of everything else that people have to think about. And then the steroids can make your moods fluctuate. So as a CNS or the nurse looking after you on the ward, we need to remember that. We need to remember to check your blood sugars and things like that. So all of these new medication, well, steroids aren't new, but all of the medications that we give affect, we need to keep them in mind when we're looking after you, and you need to keep, you know, them in mind as well. We need to let you know that steroids can affect your mood, so you just don't get taken aback by you know, emotions that don't feel true to you. The daily capsular injections, for those of you who never had them, capsular is a daily subcut injection, so it's a little needle that goes under the skin in the tummy, or the arm. You can take it, and it prevents the clots forming. So it doesn't switch off the TTP, but it's another thing like the plasma exchange that keeps your organs and you safe while we're waiting for the immunosuppression to kick in. What it does mean is there's a much faster platelet recovery, shorter hospital stay, fewer PECs, fewer lines. And when we talk to patients, quite often the lines are one of the most traumatic things that happen to them. So that it's not something that we take lightly at all. They're a risk of infection as well. So the fewer of them, the better. Kaplan has changed TTP in that previously people would be plasma exchanged for weeks, multiple lines, the hospital stays would be much longer, there would be a platelet recovery, and then quite often or sometimes the platelets would drop off again and we would have to restart. We see that much less with Kaplan. And now it is looking, you know, our average is a week, which is brilliant. But there is an implication for everyone who goes through it, in that you come into hospital, about half our patients go to intensive care, and to be at home after a week. So before, we used to be able to see our patients every day, you know, drip feed the information, tell them over and over and over again, because who can take in all of the details about TTP? I certainly couldn't, you know, in one sitting or even in 1 week when you're unwell. So quite often now people are kind of coming to terms with what happened to them when they're at home, when there's less medical support, when there's less, and it can be quite frightening, or maybe people can't really take in the seriousness of it all, because if they were that unwell, how are they home and out of intensive care in a week? So from a nursing perspective, Kaplan has been incredible, but it has meant that we have changed how we talk to patients. The other thing, you know, we do have to sometimes really emphasize, which we don't want to do, but how that, you know, you are only out of hospital because you are taking this injection. And that puts a lot of pressure on the patient because they're self-injecting it, or a relative might be. We can get district nurses too as well. But that really puts the responsibility of your health in your hands, and that can be really frightening. And cause a lot of anxiety. So we want to support people through that, because it's good, you're at home, you're in your own environment, it's better than previously, but that's not to say that it doesn't come without an implication for you. And so that's something that we, you know, as your CNS team, as your nursing team and your medical team, and there's psychology there as well, that's something we need to keep in mind and, you know, continue talking to you about, and making sure that you know how to take it, and you are taking it, because it, you know, it's serious if you don't. But that's a lot of pressure to put on someone who's dealing with a new diagnosis and probably has a life outside of, you know, outside of TTP as well, that they need, that carries on. So that's sort of, you know, a newish medication. It's standard of care now, but it has really changed patients' journeys. And then because of that, it changes how your CNS looks after you and engages with you. Rituximab is started as soon as possible because it's shown that the sooner it's given, again, fewer plasma exchanges, shorter hospital stays. And that hopefully enables remission. It does in most people, it you know, certainly a clinical remission, and then in about half of people, the ADAMTS13 will start to come back down, and at a level that is, you know, there's a rough level, but really it is independent to the patient, because it depends on how you are. We'll give elective rituximab or a similar drug if rituximab isn't an option for you. TTP now is 24-hour contact numbers for your team, a dedicated CNS, a psychologist at your centre, support groups. And these are all things that, you know, it wasn't so long ago that not many of these things existed at all. and lifelong monitoring, which is really important because that won't change. We will all, well, I mean, I don't know, I can't see into the future, but certainly the near future, they're coming for your checks, coming for your clinic appointments, talking to us if you're struggling, because the part of the nationalisation is that everyone now has a centre. We have had people who used to be looked after in hospitals that were much closer to them. Now they have to travel quite far from us. So if that is difficult financially, or talk to us about it rather than not coming, because we can do a million things to try and make it easier, arrange local testing, maybe help with the transport, things like that. So the lifelong monitoring is important, and it means that, and equally, it might not be something sort of physical about not wanting to come. Psychologically, it's difficult. We know that, coming to get your ADAMS tested. And so if that's a barrier, if you just can't face it, speak to your team, that's fine. It's okay to open up to that. We've got psychologists and we've got ways of trying to work with you to allow you to come and be looked after properly. So that, just to say, there are two types of TTP. Most people have the immune type of TTP, and that's what I've described. There is congenital TTP, which instead of your ADAMTS13, you developing an antibody to your ADAMTS13, and clearing it, and so then the immunosuppression gets rid of that antibody, so then you can maintain your ADAMTS13 levels. In congenital TTP, you are born with just not making enough of it, and you can sort of bubble along not knowing, and then an event that puts a stress on that system can trigger an acute episode. So the treatment that is at the moment lifelong. There's nothing to make your body start producing it on its own at the moment. So it's basically replacing the ADAMTS13 enzyme every 1 to 2 weeks. In children, we use 8Y, and in adults, which is a factor that contains some ADAMTS13, and not really enough. But children, there's a volume with children, they're smaller, you can't give them the volumes of plasma that they would need to have to get enough ADAMTS13. So the standard of care now is plasma infusion. So instead of the plasma exchange where you have the line and you're connected up to the machine, you have to come to a day center, have a cannula in, and have sort of 3 to 4 bags of plasma infused, and that replaces the ADAMTS. That's weight based because you can't give too much volume to someone, so they're still not getting the ADAMTS13 potentially that you would like to achieve, but they're getting enough to prevent the symptoms and sort of damage to the vessels from all the microthrombi. It's time consuming, having, with the best will in the world, there's delays, there's it's not an hour and a half, hardly ever. It does go on for a couple of hours and sometimes a day if it's gone terribly wrong at the supportive care or day centre that you're going to. Anecdotally, people feel tired the next day, or fatigue. So what is new now and what is really coming in is the recombinant ADAMTS13. So this is on trial only or compassionate use. And instead of the getting the ADAMTS13 replaced by being in plasma, it's been synthesized. So you get the you get the protein, and that's all you get. So it's in sort of 10, it's in a very small volume, 10 mils, and it goes intravenously still. But we teach people to do it themselves, and so that is revolutionary. You know, someone might not have been able to go on a 2-week holiday before, because they always have to come for their plasma infusions, and they now can, you know, take it away with them, self-administer. They don't have to come to hospital once a fortnight for, you know, they can work, and don't have to take time off from the work. So it really is, it has revolutionized. The other thing is it achieves a much higher ADAMTS 13 after the infusion than you get with the plasma. I do feel it is difficult, not difficult talking about this, but I do want to make people aware, you know, recombinant ADAMTS 13 is the future. A lot of patients are getting it now, but there are a lot of patients still on plasma infusions. And that is the standard of care and has been for a long time. And that, you know, hopefully will change in the future. And so if you are kind of logged in and you're still on the plasma infusions, there, you know, recombinant ADAMTS is coming, but it is still in trials or on a compassionate name-based use only. So it's not kind of like, it's not licensed yet. Right. So then we've sort of talked about where TTP was and where we are now. So what's next? These are the trials and the research that are sort of the big hitters, the big picture ones, and the Kaplan trial. So I spoke a little bit about how that is the subcut injection that we give to people daily while their ADAMTS 13 recovers, and they go home on it and they give it to themselves, normally between 30 and 60 days. When people newly diagnosed, or if they're in a relapse, but they're well, so there's a whole list of criteria that they have to basically not tick off. So not be neurologically or have much cardiac involvement. If they're well, but their ADAMTS is less than 5 and they are in, you know, they are diagnosed with TTP or in a relapse, we can not do plasma exchange. So just give the Kaplan, because the Kaplan and the plasma exchange are both doing the thing of protecting the organs, trying to stop the clots, replace the ADAMTS 13 while we're waiting for the sort of immune sort of system to switch off and stop making the antibodies. So it doesn't automatically mean plasma exchange. It doesn't automatically mean a line. And when I'm talking about the lines, I'm talking about the big ones that we either put in the femoral vein or in the jugular. And they are not nice to have put in. And again, they are an infection risk. So we are putting people in the trial, not many, because TTP is a rare disease, and also we want to keep people as, you know, safe. So we only put people in it who we feel it is absolutely appropriate. And what I would say about that is also the second that it would look like they need plasma exchange, they're taken off the trial. But it's been successful. There have been, you know, people treated with just Kaplan, no plasma exchange. The second one is the recombinant ADAMTS 13. So at the moment it's being used in congenital patients. That's where the trials are. There has been a phase 1 trial of it being used in immune TTP, and that is basically just to check that it is safe. It doesn't check for efficacy. It just checks that no harm is caused. But we know that because a lot of people are on it anyway from the congenital side, but you still have to do the trials. So that would again mean no plasma exchange, no being, you know, exposed to blood products. You can get high doses of the ADAMTS 13 in minutes instead of the sort of 5 hours that it takes to plasma exchange. So hopefully that will lessen any damage that the microthrombi are causing and improve outcomes for severe TTP in acute admissions where, you know, we're really having to do multiple plasma exchanges in a day for long periods of time, even with the Kaplan. So both of those are, you know, moving TTP to a plasma exchange free treatment, which I think everyone would agree is really positive. From our perspective as your CNSs, that's certainly some of the hardest times of of the diagnosis. It's the lines going in, being attached to a machine. They're big, they're loud, they're scary, and so to remove that also would remove any delays in treatment. It's most of us can pop a cannula in to give this treatment, but you need to get an anaesthetist to come and put the central lines in, and x-rays to check that the neck lines are in place, and all of this is unavoidable delays to getting the ADAPT13 circulating into anyone's bloodstream. So hopefully would improve admissions. The other thing to say is the TTP registry is still going, and it's changed a few times as in kind of what it's collecting, but without the TTP registry, we wouldn't, I don't think we would have psychologists in as a part of the care for NHS England. I'm not sure if the commissioning would have happened. It's, the only place where we've collected, all the data from anyone who signed up for it across England, and it's really important data. It's it's anonymized. You're just a number, but just to say thank you if you have signed up, because what we've been able to capture, because every person counts in a rare disorder, everyone counts anyway, but to try and capture what happens clinically and inform future treatment, when you don't have thousands of patients diagnosed a year, then it makes it much more important that, so everyone who has signed up, that's, really been incredibly valuable. So thank you. So that's ongoing, and we will continue to capture that data, and I'm sure it will inform the treatment of the future. So just to talk about the NHS service specification. So that's the commissioning in 2022. And I did touch on it briefly before, but that is in NHS England, every TTP patient, every person with TTP needs to be looked after by a TTP centre, and there are 9 in the UK, in England. So if I could just say, if you do not know if you're under a TTP specialist centre, just check. Or if you think you're not, just check, because you definitely should be. And I think most people are, but just as a little shout out, if you're not sure, then speak to your clinician, and I'm sure they'll very quickly tell you, yes, I'm sure you are. But it would just, because you do get a lot more support now that there are the centres, and it's standardised across England. So hopefully it's not a postcode lottery about how you're treated with your TTP. So there's 5 domains in the service specification that every centre needs to sort of achieve, or I guess it's the point of why the national centres exist. And again, just take care. This is, I'm talking about it from a sort of clinician's perspective. I do realise I'm talking about probably most of the people who have signed into this. So, again, just if this is a bit upsetting, but what, the domain 1 is to prevent people from dying prematurely, which is pretty major. Enhancing quality of life with people with long-term conditions, helping people to recover, ensuring people have a positive experience of their care, and treating and caring for people in a safe environment, and protecting them from avoidable harm. And I think that avoidable harm is just so important, because now we know so much about TTP and TTP care. It really is, there should be no substandard care now, because, we've got the knowledge. And so if you're in a DGH or something that, has never heard of TTP, that can affect, your outcomes. So really, that's why this commissioning is so important. And then the big green heading there is basically, this is pulled from part of the statement. Patients and their families should have access to appropriate support from a specialist nursing team as soon as practicable. Don't know if that should be practical. And I just wanted to say that comes into every step, every domain. Your nurse should be there with you. We see you on the wards. And quite sometimes you're moved from intensive care to a ward, and then you have the rest of your treatments in an outpatient setting. So to have that continuity of a familiar nurse who's looking after you and knows you well as you're an inpatient, knows what you went through in your acute admission, so you don't have to talk about it with someone. We were there, and then to be able to follow you up and see you in your clinics, check in how you're doing. That's why the CNS role is part of the service spec, because it really gives people a port in the storm. And you've got our numbers. You should have our numbers. If you don't have a clinical nurse specialist number, ask for one, because part of the thing about the nationalisation is that we got so many more patients, and so we don't know them, and clinics are busy, so we don't have a chance to chat to everyone, and just say, do you have our numbers? Reiterate, go over and over. So if you don't have a nurse for a clinical nurse number for a clinical nurse specialist, your next consultation, just ask, and you'll get it, because every centre has that. So this is the pathway for suspected immune TTP that is provided by NHS England. And I just wanted to show it because right in the middle here is this TTP specialist nurse support. So it's really soon. So, you've been seen, assessed by a senior specialist, commence with PECs, and then that's when you should be meeting us. So, and that is, I think, a reflection of how the care and support we can give to you and your family while you're in. I know I'm talking a lot about acute admissions here, but this extends the whole time from then on after. So if any of your clinic appointments or anything, if you want to bring a relative, if you want us to phone your family and just sort of go over what happened, in clinic, or talk about TTP, or anything like that. You might not have had children when your children might have been young when you had your episode, and now they're adults, and you don't you just want a professional to talk to them about it. We can give them a ring, or you can bring them in and they can meet the team. So it's all just to make things accessible, to make information accessible to you. So at the centre of the commissioning is collaboration. So it means that we're all, the centres are all talking to each other. The nurses, the CNSs are all talking to each other. It's essential for your experience, for patients and outcomes, to be of a similar standard, no matter where they're diagnosed or treated for TTP. And that will be achieved by us by outreach on a national level, and training and teaching in a regional level. So now that I'm the lead CNS for UCLH, so I go to other centres in the sort of southeast, where patients might go to for their treatments, because it's a bit closer. We organise it and kind of liaise with everyone, but I can go to the nurses on the ground who are going to be doing the treating and give them a bit of education, so they know why this patient's having plasma, when really what they're going to be dealing with is lots of patients having chemotherapy, because 9 times out of 10 that's the units where they're given. So it's just to, and then that allows the patient being treated there to have a bit of confidence that they're being treated by people who know what they've got and know why they're having it, and know what to look out for, if they ever turn up unwell. So I suppose, what does this mean for you? What does TTP then and now mean? And from a nursing point of view, the national collaboration, both medical and nursing, is to make sure that you have the support and care that you are entitled to. And I think that's key for you to take home that this is something that you're entitled to this care. You deserve it. Acute admissions have changed, but that's not to say that they're not difficult still, or there aren't more challenges, or that, you know, the way you were treated in the past wasn't wrong for then. It was best care in that moment. But it's just, you know, as time goes on, as you know, research and trials are completed, we understand more. You should have direct access to your TTP nurses and a 24-hour access to your medical team, so a number to call. If you don't, like right now, I know you can go on the TTP network and find links to it. That's something new that Joe's done. But otherwise, you know, so you can find that out now. I think it's on most trust pages, internets as well. You have support groups and psychological support now. UCLH are running a 2-monthly support group, and we can link up your clinic appointment to that day, so you don't have to come twice. And to take part in the registry or trials if you know, if it's appropriate for you, because that really does push treatment forward. So just to conclude, TTP has clearly come on leaps and bounds from being sort of a vague description to knowing what's causing it, to then having treatments and multiple treatments, you know, which we do. But I would say patients' needs have stayed the same, and it's support, it's education, it's advocacy, and that hasn't changed. It's just now we've got the tools and the resources to provide that. So that's quite exciting. You know, people have always needed to know what's going on and help and support, but it just wasn't readily available to everyone. And hopefully now that's changed. Treatments will continue to change, and that's, you know, hopefully, and that's a good thing. So as nurses, that means that what you need support with, or, you know, that will change too. So the way we care for you will evolve as well and continue to. And so please, you know, feel free to talk to us about anything, or any ideas you have about TTP care at your centre, because we're evolving too as treatments are. And so yeah, just always come to us if you have any ideas. But the fundamentals of lifelong follow-up does continue, so that hasn't changed. So you'll know your team while you're in that area, unless you do any big moves. And need to continue coming for your ADAMS 13 testing, because it's so important. And also that's, you know, we'll get to know you more every time you come.